Okay, well, if there are no questions, I think we will just speed on, Steve, and move on to your next talk.
Okay. All right. So you can see I started to put in there treatment, management, and misconceptions. Again, where are we now? So we're going to talk about medical and surgical treatment, as well as what to do about managing them. I'm just so intrigued that as I see and hear and look at horses in Europe, that you don't seem to have this problem as frequently as certainly what we have seen in U.S., and so that's good news. Well, as far as management goes, the conservative management, if they are less than 10 months of age, when I first identify them, my attitude is to go for trying to treat them conservatively all the way. In the most simple thing, what I might do is put them on prednisolone for 400 milligrams a day for 2 weeks, then another 200 milligrams a day for 2 more weeks. And, if they aren't better at the end of a month, for many of our clients, that's all they're going to get. They're either better at the end of that month or they're euthanized. Okay, and that's it. Doesn't matter what severity they are. Doesn't matter whether they're insured or not. They're going to make that sort of cutoff for them. There is a study published, presented at the AAEP in 1986, in which one farm in central Kentucky radiographed over a 3-year period of time every baby that was born before they were 3 weeks of age. So they radiographed the neck of every baby on the farm. Any of those that had a narrow vertebral canal were placed on a starvation diet. What was that? They were given 50% of what National Research Council recommended of protein and energy until they remodeled their vertebra back to normal. So they were, and then in addition to that, to prevent trauma, they were locked in a box. So they couldn't arch their heads and necks up over it. So over a 3-year period on that particular farm, they identified 18 offspring that had a narrow vertebral canal. Over 15 months was the average time it took to remodel. 17 of the 18 resolved. So they remodeled their vertebral canal back to normal. Well, that happened a long time ago. I was still at Ohio State, and we had a surgeon there who was a little bit cantankerous. Richard don't know who that was, but at times he would say things that were humorous. And one thing that Dr. Robertson said, the 18th one of that, they sent to us for surgery. And one of the things that Jim said was, if you want a horse to not do well after surgery, starve it for 2 years, because basically it did not. We did surgery on it, but it didn't do well. But of the others, they did quite well. Now, the farm thought, even though they had good remodeling of all those vertebrae, that was not a normal way for a horse to grow up, right? That is a terrible way for a horse to grow up. And all of those horses, even though many of them made it to the racetrack, they had other problems. They bowed tendons at an early time. So it wasn't a normal way to grow a horse up in a box for 15 months. So there are conservative managements that we can do. And so what generally we'll do is we will lower their level of energy and protein, not to 50%, but we want to keep them on the thin side. I like to, in simplistic terms, I like to be able to just see the ribs. So we'll keep them at that sort of body condition weight. We'll try our best to not feed them so they have big growth spurts. Obviously, sometimes we can't help that because that may be in part of their genetics, that they're going to hit times in which they grow rapidly. We also, in order to enhance that bony development, since we know there's a role for trace nutrients, we're going to put increased levels of copper and zinc in their diets. And because I have no interest in having feed companies be mad at me, what I do is I find out what feed company the farm is already using, and every company has a product that will help lower the incidence of bony lesions in the appendicular as well as the axial skeleton. So you know, if they're feeding Purina, they make a product, used to make one called Born to Win. If they feed to Buckeye, it was called Grow and Win. If they feed Hallway, it was called M30. Another company has Stam. So there are all these products that are out there. And so that way, I just pick the product that the company they're already using makes and put those animals on that kind of a modified diet. I don't put them in a confinement. I do put them in a limited exercise area, so small paddocks, usually with only 1 or 2 buddies, because I don't want them. Sometimes we can have the onset. The trauma might be what normal colts do. They're out there arching their back. They're on top of each other. They're playing in a normal way, and sometimes that will be the history that you get the day before they had the onset of signs. So I try to limit their exercise in some way. And when we do that, we've had some pretty good success. So again, in straight up terms, I like to do that if they're less than 10 months of age. I tell the people that it's not going to improve overnight, that they're probably going to need several months of modified diet as well as exercise, and then we watch them over time. If they get worse, we can always do a myelogram and or do surgical intervention. Other things that you can do, if they have a big arthritis on these articular process joints, well, you might just inject those joints, put a little steroid in there, like you would any other joint in their body, and help them. And then the last thing is, here's the surgical fusion. So it says under 2 years. You've already heard me say that mostly under the 10 months of age. This PACE diet is in the AAP proceedings, 1993, I think. Might actually be a little before that. I couldn't remember, so that's why the question marks. And these are some of the material. But usually we go for grass hay, attention to calcium and phosphorus, supplement copper and zinc, and try to keep them so they're not growing excessively fast. You can do the facet injections. I'd rather do this for horses that present with minimal to no neurologic signs. And here's why. If I'm going to inject a joint in the neck of a horse that's in the grade 2, meaning it's obviously neurologic, and I inject it and that horse improves back to normal, and then goes out and suddenly has an acute re-exacerbation of the problem and someone gets hurt, I'm going to feel really bad about that. So I prefer to do the articular facet injections on horses that are not ataxic. Now, I argue a lot with Denois. Denois is always telling me, he is a great at, ultrasounding, imaging, anatomy, and doing the treatment. So you can do that, conservative management, and help. This is what that might look like on radiograph. This is a picture of what you might see on the ultrasound. So we've got bone at the very top, bone at the bottom. The arrow is pointing to the needle, so you can actually see the joint, put the needle into the joint, remove, synovial fluid, and put a little bit of steroid or other product right into those articular process joints. And then we've already looked at this horse. You can see how dramatic the radiographic changes were on there. I've highlighted them with a lot of arrows, and then we saw this horse at postmortem. So that's what the radiographs look like on this particular horse that had that soft tissue lesion compressing the spinal cord. What about surgery? And again, I think we're going to have Dr. Phillips talk about it, but it's a modification of a procedure used on people. So it's a modification of the Cloward technique, which is an anterior interbody fusion. There are some other publications out there for people using locking plates, and I think the folks now at Colorado State, Dr. Jeremiah Easley and Yvette Naut are doing a project which they're doing another technique. This, Dr. Bagby, who I showed in that very early slide, originally developed this Bagby basket where you drilled a hole between the vertebra and the basket, or the implant was about 1/8 of a millimeter larger than the hole that you drilled, so that when you put that in there, you shoved the vertebra apart. You allowed this is packed with a bone graft that you remove from here. Originally, they did it with a bone dowel, but now then they went to this, and now we have a newer technique that twists in. I'm going to talk about that in a minute. This is an important horse to me because this horse taught me a lot right here. This was a colt that the insurance company honored the claim, and they asked if I wanted the horse. So I took the horse, and I found a lady who in Hilliard, Ohio, who took this horse. We put 2 implants in. It was positive at 3, 4, and 4, 5. We put these 2 implants in, and then 13 years after the surgery, this horse had been doing athletic things. He'd been breeding mares, never produced a wobbler. He was jumping, give kids lessons, and at any rate, 13 years later, the lady was going through a divorce. The horse had 32 feet of dead small intestine in his abdomen, and so she requested euthanasia, and so we put the horse down. Well, I went and got his neck because I needed to know what was going on. Am I terrible? At any rate, look what we learned here. When you get a really good fusion, look at the articular processes. They atrophy away to nothing. And back here at 5, 6, he's got a big joint, maybe starting to get a little arthritic change there. But people ask, how can a ventral stabilization lead to an increased size of diameter of the canal? Why don't you have to do a laminectomy, cut the bone off? You don't need to. If you get good fusion, all of those other changes that are coming from the articular processes, they go away. The big question, of course, is you're racing against time. We've got to get this spinal cord protected and no longer damaged and do it soon enough that it can heal before the horse has permanent damage in that cord. So that's going to be the really, really key question. So then other implants were developed, Dr. Bagby and Kusley. Remember, George worked on humans. Sadly, George passed away at 93 last year. But he was such an inquisitive man. I loved working with him. And then he developed these twist-in implants. This is just a couple of pictures of all of us. I told you I have to be the assistant, so my job is get the horse positioned. Dr. Woody's making sure it's all straight. We get them all set there on the table, taped into position. We put a few needles in there so it takes some radiographs to make sure that we are going at the right site. We don't want to operate the wrong site, of course, and so we try to get the film so that X marks the spot for knowing where we're going to go, and then we just go down and just try to get the implant placed. So it's a pretty bloodless surgery, you know. You just go in on that midline. We're going to chisel off the ventral spine of the affected vertebra. Tim, are you going to show this? Because if you're going to do this, do you have comment right now? If you want to have something to, if I'm talking about surgery there. But at any rate, we try to be certain, so these little pins are just guides to make sure that we're going to get an equal amount of the affected vertebra. We want to get it in on the midline, as close to that as we can. We do have a pretty large drill guide that is pounded into the bone so it will stay there and keep things in place whilst we're doing this. And there's what it looks like when the guide's in place. We start with a little core saw, and so we're cutting out a kerf. Remember, a kerf is where a saw blade was. So the space left by where a saw blade was, and we're leaving an isthmus of bone on either side. We remove most of the intervertebral disc, leave a little isthmus of bone, and then we tap this and thread the implant into place. Dr. Bagby was bold enough to ask the tailors, because he got to know them after doing Seattle Slew twice, if we could name it the Seattle Slew implant, and they said yes. So the basket implants are called Seattle Slew implants. And at any rate, this is just what we're using to widen the kerf. So this is a kerf cutter, and that's what it looks like in place. This is the tap, because in order to twist it in, you have to tap it, and then we have either half-threaded or fully threaded or half-threaded implants. The fully threaded implants we don't use very often because it seems to lock in so tight that we were getting some fractures above the implant. So we stopped. We almost always use the half-threaded now. It'd be rare for us. But we always have the fully threaded with us at all times. This is just the driver that puts it in place. That's what it looks like when we finish. The horses, it takes about hour and 20 minutes to do the surgery, depending on how many sites. And the horses, don't rush them to get up. We assist every recovery at our place. They're usually back in the stall within an hour and a half after surgery, and we usually leave a hay net up until they're eating off the floor, which is usually the next morning. So rarely do we have, very many problems because they get their head and neck up and down pretty rapidly. I don't know that we need to address, we do occasionally have some complications with you're very close to the carotid artery, you don't want to bang that causes a lot of bleeding. Then you got to put a lot of these little clips in there to stop the bleeding. We do have occasional horse that has difficulty getting up. Sometimes in the very acute phase, we'll have some horses with airway obstruction because when you are moving that away there, not only is the carotid artery there, you've got the recurrent laryngeal nerves, and so we scope all the horses, or we try to scope them all before surgery, because I'd rather know if they're a roarer beforehand, because if they become a bilateral roarer afterwards, not good. Not good. So only once did we ever get an infection in there. Rare to have the implants collapse, but we have seen that. This horse was a really interesting one, and I wish we could have time to include it. This is the last thing I'm going to talk about, but it fits well with the insurance people here because this horse had so many of the things that are related to insurance. So we put the basket in, and the implant backed out, and so this came to not only a deal, is it the right thing to do a second surgery? So the horse was insured for $400 and some thousand, and the people had used it as collateral in a loan and had established a value of $200,000 on the horse. So the underwriters then said to them that established a new cash value, so they sent the premium back for $400,000, put the horse down to $200,000. The horse had a $165,000 deductible on the policy, none of which had been used, so the horse's value now was $35,000. So the people decided not to euthanize. So we put this plate over the basket, put it back in, and we euthanized this horse last year at 19. So he went on, did quite well, covered quite a few mares and did well. He trained for a while, but never raced. Okay, I know that I've already hit the end of my time. This is one that actually came to me, but Alan Nixon had done the surgery on this horse, and I'd never seen a basket break. But poor, and Alan, he yelled at me really badly because the horse came in, we did a myelogram, we euthanized it, everybody agreed it was the right thing to do, but I didn't save the basket in the bone. He said, surely there was something wrong with that damn bone, Reed. What was wrong with you? And so he chewed me out. What about in the post-op care? Well, 30 days stall rest, 30 days hand walking, 30 days in a round pen. There's not a single recipe, but the good news is, as we see this new, this was Bill Whitman, that was the previous owner of Calumet. Bill would help us do some of the rehab. He liked to ride his horse, so we were sending him over there, and he would do some line driving and ride him on the track at Calumet. But the sports medicine and rehab group, I think, is now developing lots and lots of stuff. And if we had time, I have another slide presentation showing how we put them on these firm and soft pads to work on their balance, on the AquaTread to work on their proprioception. And there is a program that we've been using now that I think is going to make and help a lot of these horses come back and do quite well. This guy Louisville luminary. I can say his name because I own him. I own parts of 10 wobblers. He's one of the leading sires in Trinidad right now. So, who has questions? I've gone on long enough. Maybe I talk too much. Surely there's...
Well, I'm wondering, actually, since we are running a little short of time, perhaps we can move... Oh, Tim, did you want to ask a question?
One before I get up. Just talking about, do you ever do wobbler surgery on foals?
We have done some foals, some weanlings that we've done. Even though I said if they're less than 10 months of age, I suggest conservative management. But I'm trying to think, I'm sure I've got a number of them that are in that 6 to 8 months age range that have done quite well. So yes, we have done that. I just have to go to one right here. Richard, I'm listening.
Do you want me to ask the question now?
Yeah, you can ask it.
Steve, you mentioned the fact that many people are now moving towards CT myelography
Yes.
and in diagnosis. One of the issues that I see and have considered with this is that it's going to be very difficult to do a proper dynamic study.
Absolutely.
What are your comments on that?
No, I absolutely, I think our CT unit that we're putting in, we're going to do the body tom. That's the one we're putting in. My guess is that a lot of horses are going to have both. I think I'm going to do a myelogram. And one horse that comes to mind, a horse that was a dressage horse that we did, and he just reeked of being a wobbler, and everything, and his myelogram was clean. They sent him from New Bolton over to us. They took him back to New Bolton, and they used that new robot, did a CT myelogram, and he was compressed from the sides at 3-4. We'd called him clean on our myelogram. We did surgery on him, and the guy just sold him 4 years later. So I worry, Richard, that we may end up doing multiple studies on these horses. And again, not to be cavalier, okay? And I wouldn't, there's always a concern about, myelography. And I don't want to, suggest anytime you anesthetize a horse that it's not a risk. But in the last 10 years, we do average 1 myelogram a week. And it's been that way for 10 years that I've been at Rood and Riddle. And I can count on one hand the number of horses that didn't get up after their myelogram. So whilst it is not, it's not that big of a risk for me. Now, we're done in 45 minutes. We get them in, we get them down, they're back up, and they're in the recovery stall. We take usually 9 radiographs. I'm not real big on DV shots, so I don't take very many of them. Occasionally I will. But then the other thing that I think is improvement, as one of the misconceptions is, we published this, that they only improve 1 grade. Well, of the 160 that Dr. Woody and I have done, 104 improved 2 grades or more. So I think that they can do quite well. The other thing that I think that's important to say is that many of these, the idea of this surgery is that it's going to just be sort of they're going to march to another site. We've had only a few horses ever develop a lesion at a second site that we've had to operate. And when we went back and looked at their myelogram, we probably should have operated at that site the first time. And the other thing is that it's going to be a salvage procedure. We have lots of horses that are doing athletic events, jumping. Some are racing. It's tougher on racehorses because, 4-year-old maidens are tough to start. When you get that. So you got to get them early if you're going to do it on racehorses. And then I've got horses, like I said, that one that I showed you is 13 years after. The second one I showed you, the insurance issues, 19 years after the surgery, So some of them, if you fix them, they'll do well for a long time.